Good afternoon, everyone. Good afternoon, Dr. Croft. Very good. Yes, Mr. Gill, when you're ready.
Thank you, my Lord. Over the course of yesterday and today, there have been questions submitted to us in terms of our Rule 9 procedure. 4 questions were submitted to us yesterday. Today, a total of 41 questions have been submitted to us to be put to Dr. Croft. Of those 41 questions, I think a total of 6 have been rejected, and we are prepared to ask the remainder and all of the 4 questions that were asked yesterday. So if I can begin, Doctor, good afternoon again.
Good afternoon.
If I can begin with the questions that were put to us yesterday for consideration by you. And I'll deal with these 4 questions in not necessarily in order. One is relatively short, and it's said that during the course of the UK COVID-19 inquiry, there was evidence that the precautionary principle was not a legal concept, but an epidemiological one. Do you accept that?
I'm not, well, of course, I don't know what evidence is being alluded to there, so I can't comment on whether that's factually correct or not. The precautionary principle is sometimes cited in public health, in textbooks and journals. It wasn't a concept that I was formally trained in, so it's relatively new as an idea, but I can see that it has some benefit in being applied to public health, and I accept that there will be occasions when it can usefully be deployed as a talking point, as a basis for discussion.
I think we saw yesterday that Dr. Tegnell, in his book, had a particular view on that. And I think you were aligned with Dr. Tegnell's view on the precautionary principle.
Yes, if I remember correctly, he was saying that the precautionary principle can be used carelessly, I think is the word he used, as a means of pretty much throwing everything you've got at a problem instead of being selective in the in the way that you approach a particular emergency.
Can I move to another question submitted yesterday, which is that you suggested in your evidence that the idea was that lockdown would stop transfer of the virus using a light switch analogy. And it is requested that we ask you whom he understood to be suggesting that lockdown would turn off transmission as a light switch. The questioner believes that they are aware that in the evidence to the UK inquiry, there's been no suggestion, particularly from any CMO or Professor Whitty or Professor Valence, that the contemporaneous thinking was that lockdown would switch or off transmission like a light switch.
No, excuse me, thank you, Mr. Gale. We were having a discussion about Dr. Tegnell's memoir, of which we have extracts that we considered simply because they represented a rather different approach to what we adopted in the United Kingdom, and therefore one from which we potentially could learn. And it was in the context of him talking about how he was invited to take part in the September 2020 virtual meeting with Boris Johnson and his team. And he says there, shall I find it? He talks about how the scientists came in and they talked about a circuit breaker lockdown circuit. And I thought, well, that's an interesting word. And
well, perhaps I can just put to you what you actually said.
Oh,
yesterday,
yes, thank you. Yep.
Which may be helpful.
Yep.
Because you're talking about this, and it was you who introduced that particular reference in Dr. Tegnell's work. And this, my Lord, is at page 56 of yesterday's transcript.
Right.
And you said, you referred to the meeting in September 2020. So there was a lockdown in November. The whole of November there was a lockdown. It was, again, they thought, well, we'll have a lockdown and we'll completely interrupt transmission. But there may have been some impact from the lockdown. But I just think it's an interesting concept that this is how lockdowns were viewed, or somehow completely cutting the ground from under, and somehow completely cutting the ground from under the feet of the virus. And yet, that's the reality as far as I could see. And I then asked you about the drag of time.
Yeah.
And you said that would be a short interval. And I then asked you, with the drag of time, there would be an interval before it became effective. And you said exactly yes. But the level of effectiveness would be high. Yes, you said, after the latent period of a couple of weeks, yes, it would be dramatically high. It would be breaking the circuit, which is like going from, using an electrical metaphor, going from having your lights on to having no lights on at all. So can you just give perhaps a little more content to what you were saying there?
Yes. Well, this actually was the very first question, on the lines of the very first question I was asked in my supplementary report, where, if you remember, there weren't any further questions on it, so we haven't highlighted it, but I was asked if there'd be utility in looking at the graph, the curve of the epidemic, and maybe interpreting it for the benefit of the inquiries, COVID inquiry. And so that was my, so I actually did that. And then I talked a little bit about, that's how I started off my report, and I talked about how the lockdown started there, and had it been instantaneous or near instantaneous as was presumed to be the intention, there would have been a complete reduction in cases there, but that didn't happen. The cases, they were falling, but they'd already started to fall very soon after that. So that was the context of my remark about the instantaneous. But I was interested that Dr. Stegman had picked up from his discussions this phrase about circuit breaker, and that seemed to me to represent what was a general argument that was being put forward to the Prime Minister at the time about how lockdowns would be dramatic, but pretty instantaneous and pretty complete.
Yes. Thank you. The next two questions, which I will run together, relate to your evidence concerning the question of regard being had on as a downside of lockdown to the effect on mental health.
Yes.
Preliminary on that, you're asked what experience and what professional experience do you have in relation to the area of mental health? Do you have any?
Yes. Well, I I trained in medicine in London, and it was broad-based training. Once you qualified as a doctor, which I did, you go on to either become a general practitioner, which remains broad-based, or you specialise into one of the other specialty areas. And so in the broad-based training, we spent some time attached to psychiatric departments. We went to a psychiatric hospital, spent a couple of weeks there. So we had some flavour of what psychiatry was about. It was extremely interesting, but it wasn't what I chose to take up. And so that was the training. And then I worked for a while as GP and saw patients with mental health difficulties and endeavoured to help them. Then once I specialised in public health, mental health is an important aspect of public health. And it affects all kinds of considerations that are relevant to public health, and it's considered one of the important determinants of health, as I think I mentioned. So mental health has always been there in some shape or form throughout my medical career.
Yes, and I think it's important to appreciate that what you are giving a view on
Yes.
is the appropriateness of having regard to matters and identifying mental health in the context of ordering a NPI such as lockdown.
Yes, and I think, thank you, Mr. Gunn. I think yesterday, my lord, I was saying how I think I used that jargon term. The social networks, and how I said how important social networks are, and they are very important determinants of health and longevity, and increasingly recognised to be so. And those social networks would have been very largely wiped out by lockdown. And I didn't say any more than that, but that's surely is self-evidently the case.
Now, the other question associated with the issue of mental health is prefaced by suggesting that you yesterday had indicated that no consideration was given to the issue of the effect on mental health, presumably in the context of planning for a lockdown. Now, it's obvious that you weren't in the room when these discussions took place.
And when the UK discussions were going, no, I wasn't there, no.
But can we just be clear what you actually did say yesterday? Because I think this question, with respect, proceeds on a false premise. This is, my lord, at page 62 of yesterday's transcript, and line 11. And I put the question to you, as a public health expert and epidemiologist, should or could the potential effects on mental health prior to announcing a strict lockdown have been taken into account? And your answer is this: yes, obviously mental health is to a very large extent determined by one's natural resilience and also one's interaction with people around one, whether at work or at home. And increasingly, it's recognized that one of the determinants of longevity and good health in older age is the social networks. That's a good jargon phrase, you say. Social networks that people have. A health professional would say, well, so-and-so is being discharged home and has got good social networks, meaning that his prognosis is going to be good and he or she will have a good quality of life at home. So a lockdown immediately cuts away all of that social network dimension of health. It just blocks that out. And mental health will suffer, as will physical health, and that certainly should have been factored into the lockdown. Now, I don't read that as you saying that it wasn't.
Whether it was or not, I know no more than yourself, Mr. Gale, but it should. I said it should have been factored in. Yes, that's as much as I said. Yes.
Thank you. Now, can we proceed now to consider some of the questions that were been asked this morning? And as I've indicated, some of these have been rejected. But going to the questions, this is again from the Scottish COVID Bereaved Group, and it begins regarding your views on face masks. And it's in these terms. Dr. Croft was asked about his views on the use of face masks and respirators. He stated in evidence that while there was a sense amongst care home workers that they should have been wearing respirators early on but weren't, but that his view was that respirators wouldn't have given them any additional protection. Elsewhere on this topic, Dr. Croft stated that all he could do was draw the attention of this inquiry to the best summary of the evidence, the most reliable summary of the evidence, which was set out in Appendix 5 of his original report. I don't need to go to that. It then goes on to refer to Appendix 5 and the references there in to the Bundegaard and Abeluk trials from 2022. And you are then asked, have there been any further studies or reviews of studies of the use of masks and respirators during the pandemic since 2022? And if so, what are they?
This is the question. I think I, to some extent, may have answered that because I expressed the observation that the Cochrane reviews stand as the summary of the best available evidence at the time they were produced. And as a Cochrane reviewer myself, it's incumbent on us to update our reviews immediately if new evidence comes along that substantively changes our conclusions. But if new evidence that comes along that doesn't substantively change the conclusions, the reviews generally tend to be updated about every 4 or 5 years. So because these reviews there hasn't been any emergency update, any new evidence that might have come along is likely to be on the same lines as that that's already been presented. So there may be new trials, but I'm confident that if there have been new trials in any of these 3 areas, the vaccines or the barrier methods to prevent transmission, they won't have materially altered the reviewer's position.
I think yesterday you made reference to, and I think it was a randomized control trial involving nurses in Ontario.
Yes, yes.
And that, I think, was a situation where one was, or those who conducted the trial were comparing the wearing of respirators and the wearing of ordinary surgical masks,
yes,
if I can put it that way.
Yes.
That obviously, I think, predated
yes.
The pandemic by quite a margin. I think it was in 2012, I think you
yes,
either told us or...
Yes, they call it low of 2009, but the message of that is still relevant at the moment because they were looking at the effectiveness, the relative effectiveness of ordinary masks versus respirators in preventing the transmission, the acquisition of respiratory viruses, and part of that trial also overlapped with the pandemic that was occurring then, which was the swine flu pandemic.
Yeah, and can you just remind us what the conclusion of that trial in 2009 was?
Thank you. It's a very important trial, and the Cochrane reviews several times allude to it as a model of what a good trial should be, and how that methodology should be replicated in other settings, not just in hospitals. So it was Ontario tertiary hospitals, and nurses were there are about several hundred nurses were involved, and they were randomized to either wearing a respirator or an ordinary surgical mask, and they were followed for a number of weeks, approximately 97 days, and the outcome that was being investigated was whether or not they were likely to pick up an acute respiratory illness. And after the period of study, the authors conclude that among nurses in Ontario tertiary care hospitals, use of a surgical mask compared to a respirator resulted in non-inferior rates, meaning they were the same, resulted in non-inferior rates of laboratory-confirmed influenza. So it was really an influenza study, but that's nevertheless, the results of that finding would be generalizable to other respiratory viruses. So in other words, the wearing of masks and the wearing of respirators gave the same degree of protection.
Thank you.
In that hospital setting.
Yes. Would that be comparable to a care home setting?
I guess it would be, yes, yeah.
We are then asked to refer you to a review. It's entitled Clinical Microbiology Reviews, or that's, I think, the journal in which it's published. And it's titled Masks and Respirators for Prevention of Respiratory Infections, State of the Science Review. The lead author is said to be a Professor Tricia Greenhalgh from Nuffield Department of Primary Care Sciences. Were you aware of that? I'm aware of Professor Greenhalgh's work. I have never met her. She's a GP by background, now become academic. You are then asked a number of questions about the content of that review, and again, I think you, by saying you haven't had access to it,
I wasn't aware of it.
There's not really very much point in asking you questions that are going to be met with a negative answer. Do you know anything about that particular review? Have you?
Well, it sounds as though it's a review of various papers with some comments thrown in by Professor Greenhouse. So it doesn't sound like it's a systematic review of randomized control trials, because there would be no point in her replicating work that already exists in the public arena. She's chosen to perhaps look at different studies that, by definition, won't be as reliable in terms of their results as RCTs.
I think we probably have all come across the expression literature review.
Yes.
Is that what this review strikes you as being?
It sounds like that, and that's the old-fashioned way that literature used to be evaluated, just lined up and rather subjective comments made about the quality of the studies and the quality of the findings, and then some general conclusion at the end. And I have to say, in the past, I've done such a review myself, but nowadays I wouldn't think of doing such a review, because it's a rather old-fashioned way of assessing evidence, and subject to all kinds of subjectivity. Is a much better way is to be rigorous in the way the Cochrane reviewers are. They just take the numbers.
Well, against that background, Dr. Croft, I'd like to put to you a quotation from that review, and it's set in the context of the limitations of RCTs in relation to mask wearing. And this is, again, has wider implications in relation to your position that RCTs remain the gold standard of work that informs medical science. And the quotation is this. Sorry, it's rather long, so forgive me. Expensive and long duration. Unless informed by mechanistic understanding, interventions may be suboptimally designed, leading to underestimation of efficacy. Cannot measure biodirectional effects on wearer and source control. Some methodological variations, including measurement of outcomes. Interventions may be heterogeneously applied across trials, continuous versus intermittent N95 use. Variation in disease prevalence may lead to underpowering. If outcome is a communicable disease, outcomes in individuals is randomized to different interventions within a closed setting, such as a household or hospital, are not independent. Cluster randomization must be used. Limited external validity. A negative result cannot prove the lack of efficacy under other conditions. And lack of difference between arms in the absence of a no-mask control arm may reflect equal inefficiency or equal efficiency. Ethical concerns if researchers are not in equipoise. Now, there's a lot in that. As I read it, that is a summary of what the author, Professor Greenhalgh, is saying about the limitations of RCTs in relation to mask wearing.
Yes. Well,
Now, can we go back a step? You've mentioned which is why I asked you about it, the Ontario trial.
yes.
Now, and I think you gave a commentary on that, indicating that, in your view, that was an extremely well conducted and thought out trial. Can you just, perhaps mindful of what a lot of those criticisms were, address some of them in the context of the Ontario
Yes,
trial?
I have to confess I haven't actually read the Ontario trial in its entirety. I've just taken the summary which appears in the Cochrane Review, and I just thought it would be useful to home in on one particular trial that was done under pandemic conditions to show that this sort of very important research can be done under these difficult conditions. And at the end of that summary, that's where that phrase comes from. And this is what the Cochrane reviewers say: this is a well-designed and conducted trial with credible conclusions. So several times they use that as a model for the kind of studies that can be done, not only in this setting, acute tertiary hospitals, but potentially in other settings as well, like nursing homes, if it's deemed that there might be some difference in outcome in a different setting. So Professor Greenhouse, has a history of being a bit against randomized controlled trials. For some reason, she feels that observational studies can sometimes provide as good evidence, but I'm afraid she's wrong. She's wrong, and she's completely at variance with modern practice. And perhaps I could again quote what is said in, because this has come up a few times, but this is what Harrison's latest edition says, and I think this will really say it all. Observational reports of treatments for COVID, and we can consider their observational reports of mass studies as well, fuel the confusion. Many of these studies are small observational studies and cannot resolve key uncertainties, often have substantial limitations. So I'm just putting back at her what the standard criticisms are of the sort of point she's making. These type of studies may generate important hypotheses that can then be tested by randomized controlled trials. So again, I say again, the major tools needed to develop reliable evidence consist of randomized controlled trials, supplemented strategically by large observational registries. That really means registries of deaths and important events, but it's randomized controlled trials that provide reliable evidence, and only randomized controlled trials. And it's because of this that journal editors, if they're presented, and I've been a journal editor in my field, if they're presented with a study that's observational and the authors say, this study shows that this drug is better than that, they say you can't say that because it's an observational study. You can only say this study suggests that drug X might be better than drug Y. But if it's a randomized controlled trial, you can actually say this study shows that drug X is better than drug Y, or not as good as, and then you follow that up with your confidence interval, the degree of confidence you have in that statement. But this is the basic principle of modern science. That randomized controlled trials are the way of venturing into certainty away from uncertainty. Observational studies maybe point the way towards certainty, but they don't contribute to certainty.
Given that you haven't had access to that review, and certainly not an opportunity to fully consider it, there is then a question put, which I will put, albeit we don't know the precise conclusion that it's made, and so one has to accept what is said by the questioner. The question is this: does Dr. Croft agree with the finding of the review that masks, including face coverings and disposable medical masks, help reduce the spread of respiratory droplets and aerosols?
Well, that may be the finding of the review, which has incorporated a lot of different methodological studies, but it isn't the finding of the best evidence as is summarized in the Cochrane Review, and that's, I went to some trouble of explaining that in my original Appendix 5, where I also looked at the Danish study and the Bangladesh study that had been done in COVID time, and they equally found that masks didn't appear to have a significant effect on the transmission of SARS-CoV-2.
There is then I suppose, more specific question, which is, do you agree with the finding of the review that respirators provide a higher level of protection?
I completely disagree with that, for the reason I've just mentioned, that Loeb didn't find that at all. Yes. They found they found that they provided the same level of protection.
Now, can we move on to the general subject of lockdown?
Yes.
A number of questions are posed about this, and we can just set the context for you of these questions. The questioners say this: during the course of his evidence, Dr. Croft stated that there is no evidence from good quality research to support lockdown as a measure for containing or slowing the spread of a respiratory infection or respiratory infections. Dr. Croft also expressed views as to the utility of contact tracing. Now, I'll come to contact tracing in later, but if we can continue on the matter of lockdown, there is then a reference to Professor David Heyman, Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine, prepared an expert report from the UK COVID inquiry, and the reference is given to that report. Have you read that report and considered it?
I did read that report in the early stages, but it was a long time ago. I haven't read it, reread it recently, so I'm a little bit hazy as to what it said.
Yeah. And the follow-up of that is, are you aware of the literature referred to in Professor Heyman's report?
I recall that he did cite a lot of literature, but I was somewhat concerned that he didn't make the, in my view, very important critical differentiation between high-quality literature and variable or even low-quality literature. He seemed to be citing literature almost indiscriminately, in my view.
Thank you. There's then set out a number of paragraphs from Professor Heyman's report to the UKI. And the small orders, the references paragraphs 113 to 115 of Professor Heyman's report. And in order to set the context of this question, I'm afraid I'll have to read it all to you. It is this: early in the COVID-19 pandemic, studies in Japan traced contacts of persons with COVID-19 forward for isolation and monitoring and backward to the source of infection. They then shut down those areas where transmission was shown to be occurring, many times in nightclubs, gyms, and other public spaces, until preventive measures could be reinforced at those sites. Such precision and long-term and short-term lockdowns demonstrated that, unlike influenza, initial COVID-19 outbreaks could be contained and transmission interrupted. The same was true in Singapore and South Korea in early outbreaks that occurred in religious institutions and nightclubs. Many Asian countries continued to keep transmission at low levels before vaccines became available by outbreak investigation and precision lockdowns at the source, similar to those used in Japan. As at 19th February 2023, Asian countries had reported fewer COVID-19 deaths per million in the population. Japan, 566, South Korea, 680, Singapore, 294, compared to Italy, 3,150, the USA, 3,344, and the UK, 3,038, attesting to the effectiveness of their containment strategies through, though other factors, including the level of comorbidities and obesity, may have also played a role. The strategy of outbreak investigation and precision lockdown was in part possible because of the early response to importations, including travel restrictions and testing of incoming travelers. In areas of the world where early response was not attempted or was ineffective, surges of transmission occurred at many different sites. Other measures, such as complete lockdown, were then applied in order to attempt to protect healthcare facilities from being overwhelmed by the surge of patients that was foreseen. and to decrease transmission of infection in the community and save lives. So that all begins, I think, with the premise that one is looking at studies in Japan and applying those to other Asian countries where precision lockdowns occurred at an early stage. Do you have any comment to make about that?
Yeah, well, first of all, I have great respect for Professor Heyman, and I cite him frequently in both of my reports because he's American and he practices in Britain as an academic, and so I don't wish to decry his opinions, but I think he's talking about something different to lockdown when he uses the word lockdown. He's talking about focused closures of certain institutions, whereas by lockdown we've come to understand the shutdown of the whole of society. So what he's saying there is rather different to what our experience was of lockdown. But it does seem to be the case that in some Far East countries, they were able to act very quickly to produce these targeted precision closures of foci of infection, and that seems to be quite effective in either halting or significantly slowing the spread of the pandemic. And there may be historical reasons for that. And there may be sociological reasons why they were particularly, should we say, compliant with that sort of approach that wouldn't necessarily apply to us. But these were countries that were still remembered the SARS experience, which affected them much more than it did ours, and so they were ready for a repetition of something like SARS, and they would have had coronavirus kits ready or the capability to produce them rapidly. They might even have been on the shelves, and in a form that could be modified for the new coronavirus. And I suspect they also had software systems that could be used for this purpose, because that's what they'd been threatened with in recent times. So they're unusual societies in that sense, in the sense that they were ready for something like a coronavirus outbreak, in a way that we weren't to the same extent. We were still planning for an influenza virus, so that requires a different sort of approach, slightly different approach. Yeah.
Yes. In terms, what is being said under reference to Professor Heyman, and this inquiry will hear from Professor Heyman in the near future.
Yes.
In terms, what seems to be being said is that, and I summarize and probably do it in gross injustice, but I summarize by saying that if you went hard and fast and early in relation to a targeted lockdown, that of itself would be beneficial in restricting the spread of the virus. Is that something with which you would agree?
Yes, I'm a bit uneasy about the use of the word targeted lockdown. I'd say sort of focused closure. Focused closure, because lockdown has, in my view, one meaning and one meaning only, and it's a drastic step. It's capitulation to an overwhelming problem. That I'm just trying to look at the definition I give of lockdown. So this is my definition. I think lockdown. It's Annex 4 of my supplement, and a term for a range of extreme physical distancing measures, first introduced in China in 2002, 2003 against SARS, and including the closure of schools, workplaces, non-essential shops, sporting and entertainment venues, a move to remote working, banning mass gatherings, curfews. So that's lockdown. It's the nuclear weapon, if you like. Whereas what he's advocating is precision strikes against these sources of infection, which they were in a position to do, but in this country we weren't. It seems we weren't.
If we use the term restricted or restrictive measures, which obviously can be cumulative.
Yes, indeed, my lord. Yeah.
And I suppose that if you have a range of restrictive measures, or the restrictive measures themselves are very wide and extreme, then they may have the same effect of what we have come to call lockdown. would you agree with the proposition that that might be more measured and suitable language because it's more flexible? It could apply to focused intervention, and equally, if there were a lot of restrictive measures or they were very wide, it would be capable of encompassing lockdown, as we have come to call it.
Yes, I agree. It's a word that's become quite emotive, but when we talk about lockdown, I think we talk about what we remember as being stuck at home and not being able to go out, not being able to go to the pub and so on. So it seems that Professor Hayman is using the word slightly differently to how we would now, and of course this is evidence he gave in 2023, so the concept was still relatively new then.
So, following on from that, Dr. Croft, is a question which again I'm afraid uses the word lockdown. Do you accept that the evidence referred to in that passage from Professor Hayman's statement supports lockdown as a measure for containing or slowing the spread of the virus? And if so, why not? I think you probably answered the question.
I think it supports the idea of focused, short-term, targeted closures of known foci of infection. And indeed, we do that in public health all the time. Yesterday I was talking about the nursery in Ireland that had to be closed completely because of E. coli was being transmitted. And it was closed for 2 weeks and then it was opened again.
You are then referred to paragraph 118 of Professor Hayman's report.
Yes.
And the quotation is given, and I'll read it to you. It was clearly demonstrated that effective lockdowns within a country could decrease transmission and therefore decrease sickness and death from infections prior to the availability of vaccines. Other results of lockdowns are presently being assessed, including the impact on mental health, youth, and education. Those collateral areas of damage are according to Professor Hayman, still under consideration.
Well, there he seems to be using lockdown in the more generally accepted sense as a societal closure.
You're asked whether you are aware of the literature on which Professor Hayman's opinion is based. I assume it's the opinion that is expressed in that passage, the long passage that we quoted.
Yes.
I think you've indicated that you were aware of Professor Hayman's report to the UKI, but that's sometime since you read it, so that I don't think you can. I want to put words in your mouth. It's probably unlikely that you can remember exactly
I can't remember
that he referred to.
Yes, he's using individual examples that have some interest, but I still think it is the case that there's been no rigorous evaluation of lockdown in its broadest sense as an effective measure, an effective and safe measure for containing respiratory virus epidemics ever carried out. It's just been taken as read that it will work, and that hasn't been proven.
Thank you. There's a slight variant on on the question that I've already put to you, but I'll put it again in terms. Does Dr. Croft agree with Professor Hayman that it was clearly demonstrated that effective lockdowns within a country could decrease transmission and therefore decrease sickness and death from infection prior to the availability of vaccines?
Well, yes, if we substitute the word targeted closures for lockdown, then if you could move quickly and target those pinpoint and through early testing and those locations and those localized activities that are fueling the spread of the virus, if you're able to do that, then that's good. That has to be good, and it will slow the transmission of the virus in the community at large.
I suppose if one takes Professor Hayman's conclusion from the second quotation that I gave you, that it was clearly demonstrated that effective and qualifying it with your words. Lockdowns within a country could decrease transmission and therefore decrease sickness and death from infection prior to the availability of vaccines. You're then asked whether you agree or disagree with that conclusion.
Oh, I think I've just indicated I agree with those caveats, yes.
This is a rather perhaps a sort of tautological question, but it's this. On which studies do you base your conclusion that there is no evidence from good quality research to support lockdown as a measure for containing or slowing the spread of respiratory infections?
Well, there are no studies by the nature of the observation, yes. Yeah.
Thank you. Can I move to I think the final set of questions we have for you from Scottish COVID Bereaved, and these relate to contact tracing.
Yes.
I think for those of us of a certain age, your use of the word yesterday of a snazzy and modern device to facilitate contact tracing using mobile phones was probably hit home. But you're referred to that passage from your evidence yesterday, and you say, but it was not something that really, with hindsight, was ever going to work. And people had to sign up and download an app, and I think only at their height, not even half the population ever did so.
Yeah.
So it was doomed to failure.
Yeah.
That's what you said. You are then referred by the questioners to work by Professor Christoph Fraser, who is the Moe Family Foundation Professor of Infectious Disease Epidemiology, based at the Nuffield Department of Medicine at the University of Oxford. And we are told he gave evidence to the UK COVID inquiry in relation to contact tracing. Are you aware of Professor Fraser's evidence?
I'm not aware of it now.
And it's the questions go on thereafter, which unfortunately I think probably I've agreed to put, but they probably are cut off at the knees by your answer to that question. And it's as part of his evidence, Professor Fraser stated that he and his team have used mathematical modeling, pathogen genomics, and big data analysis to understand the drivers of infectious disease transmission. Rhetorically, you are asked, have you carried out such research?
No, obviously this professor is a modeler, and I'm not a modeler, I'm a public health physician.
Yeah. There is then a reference to Professor Fraser's work in analysing the SARS-CoV-1 outbreak. Can you explain what that was?
Yes, that was. Can I refer to my original appendix here, my lord? So the SARS-CoV outbreak was if you like, it was the precursor of SARS-CoV-2. And it occurred in 2010. SARS was recognized in China in November 2002 and affected 29 countries across the world, so not all countries, but mainly Far East countries. By February 2003, eventually it died out by July 2003. So it's an acute respiratory epidemic, similar to COVID-19.
Yes. I think what you're being asked is whether you are aware of Professor Fraser's work in considering or analysing that pandemic.
I wasn't aware
Or
of
that
that.
epidemic. Yeah. Again, you're then asked, are you aware of Professor Fraser's work prior to the outbreak of the pandemic? I assume that's a reference to this pandemic that we are discussing.
Yes, SARS wasn't a pandemic,
Yeah,
it was an epidemic, of
epidemic,
course.
yeah. In analysing emerging infections and modelling test, trace, isolate and quarantine.
I'm not aware of Professor Fraser at all. No disrespect to Professor Fraser. But he's a modeller, he's in a different field of inquiry to myself. Yes.
Yes. Would you necessarily expect to be aware of what his work would be?
No, I'm sure he's written lots of papers that have a lot of mathematics in them that would be impenetrable to me, though I could to some extent follow them. But he's a mathematician and a modeller, and they use a special vocabulary as we do in our field.
And so I think I can take as read your response to questions concerning the process carried out by Professor Fraser and his team in developing a contact tracing app during the pandemic.
I'm not aware of what the process was.
Then perhaps more focused, in reaching his views in relation to the effectiveness or otherwise of contact tracing, what, if any, regard did you have to Professor's public report, which is different, I think, from his evidence to the UKI? Again, I think you're not aware of that.
I'm not aware of it now.
And again, there's another reference to another updated report by Professor Fraser. And again, I assume the same answer to that.
Oh, yes. Sorry, I got distracted by what I'd actually told inquiry about modelling, and if I could read this out, I think it's relevant. I said, and this is my last phrase in my original background to COVID. And I'm quoting this great Swedish epidemiologist Johan Giesecke, who says, it's possible to model the behaviour of SARS-CoV-2 infection. No model, however, will be better than the assumptions on which it can be built, on which it was built, and disease models are typically phrased in mathematical terms, which can make them difficult to understand for the non-mathematician and also lend them an air of exactitude that they seldom merit. That's Professor Giesecke, who's has informed for your modelling, and that's what I left the inquiry with. That's my last general background point to COVID, and I stick with that point. It seems to me to be relevant here.
You're then asked about Professor Fraser's statement at paragraph 47 of his written statement to the UKI, that his research showed that the contact tracing app had benefits in terms of reduced epidemic size for all assumptions about uptake of the app, and can achieve substantial reductions in mortality when combined with moderate levels of social distancing. It's then said that this is at odds with your evidence to this inquiry. Do you consider that Professor Fraser's research is incorrect? And if so, why?
Well, I'm not competent to judge Professor Fraser's research, and nor do I know the context in which he made that statement, but it is a matter of record that the test and trace system in England was abandoned after, I think, 18 months. It was just stopped. It was no longer funded. And at that point, it had cost many billions of pounds. So that doesn't argue for a system that was particularly useful if it had to be abandoned after that expenditure of money.
Okay. You're then asked about the title of one of Professor Fraser's papers, on which it begins epidemiological requirements for app-based contact tracing of COVID-19. I think you've indicated you're unaware of that paper.
I've never.
But you're asked, what are the epidemiological requirements, or what would be epidemiological requirements And I suppose if I put it generally, what in your view would be epidemiological requirements in terms of modelling?
Is it in terms of modelling or in terms of
contact
making an
Well,
app?
it's a contract, I suppose, modelling for that app. Yeah.
Modelling for an app.
Yeah.
Well, the first requirement, of course, is you have to have a reliable test so that you can be quite sure that you're actually pursuing, you're studying what you purport to study. So, for example, in the case of TB contact tracing, you have to have confidence in your index case of TB, and that you do contact tracing of all the other people who might have been in contact with that TB case, and you send them for initially chest X-rays and other sort of tests to establish if they've been infected. So there's a place for contact tracing. I'm not against it. It's a key tool of epidemiology and infection control. But this type of large-scale electronic testing is new and very expensive, and on a population scale, it doesn't seem to me to have been contributed usefully, as shown by the fact that it was abandoned in the course of the pandemic, at least in England and Wales. It may have had utility in limited situations in these Far East countries where they're better prepared for that approach.
Let me ask you a question.
Yes, my lord.
Which, since I've got to make recommendations, might be relevant, and that is that you've said a number of times that the attempts to introduce contact tracing in the United Kingdom appear not to have worked.
Yes.
There may have been technical reasons for that.
Yes.
May have been reasons in relation to the design of the app or the methodology.
And the scale of the task was another one, yeah.
But technology
Yes.
and the use of technology appears to, those of us of a certain age will confirm this, appears to have advanced very rapidly in this past 15 or 20 years. I suppose it's possible that the day will come that there may be methods of using technology without intruding unreasonably or unconstitutionally individuals that might be of use.
Yes.
Is that a fair,
I think so.
very hypothetical
Sure, yes.
question?
But from the infectious disease perspective, there has to be certainty about the diagnosis.
Yeah,
you see, and that's the difficulty about the contact tracing. It was depending on people who had tested or self-tested positive, and there were so many false positives. And then the nature of the contact, people were being pinged through the wall of the next door flat because they were within 2 meters of somebody. The app identified they're within 2 meters of somebody who had tested positive, so therefore potentially the methodological flaws seem to be very great in the system. But yes, you're right, my lord. Potentially they could be overcome at some point in the future. Yes, and it does seem that this technology does seem to have been applied with some benefit in certain countries, Far East countries that were ready to use it or poised to use it, but using it in a much more focused way instead of on a population scale.
The final question I have for you relates again to Professor Fraser's evidence to the UK inquiry. And it's put it to you simply for your comment.
Yes.
He said, or it is said that he said that, quote, with conservative estimates, up to September 2021, about 1 million cases and 9,000 deaths had been prevented by the app. Do you agree with these findings? If not, why not, effectively?
I don't know on what basis he made that calculation, so I can't possibly comment. Mr. Gale, thank you.
No, those complete the questions that I have.
Very good. Thank you very much indeed. That, I think, then concludes the evidence for Dr. Croft. I'd like to thank you again very much, Dr. Croft, for coming and giving us your time and the expertise that you've brought to this. We finished the first part of this series of sessions, and tomorrow we will start 2-day hearings in relation to international approaches, when we have the pleasure of Dr. Tegnell, whom we've heard a fair bit about in the past 2 days, and Sir Ashley, Bloomfield. It's disgraceful of me to forgot the gentleman's name. And they'll both be here tomorrow. He, of course, was involved in the pandemic management in New Zealand. So we'll start those hearings at 9:45 tomorrow morning. Thank you all very much indeed.
All right.
I'll have a quick word.